Good afternoon, and thank you for attending my paper on motor neurone disease and assistive technology, exploring the unique challenges faced in rural and regional areas. Motor neurone disease is a rapidly progressive, life-limiting neurological condition. Every day in Australia, 2 people are diagnosed and 2 people with MND will die. Average life expectancy from diagnosis is 27 months. And the incidence has increased by 250% in the past 25 years. The Hunter New England Central Coast Primary Health Network accounts for nearly 25% of the total number of people living with MND in New South Wales, according to a New South Wales MND 2023 survey. On the Central Coast, neurologist Dr Anna Schutz has put together an MND multidisciplinary clinic, including allied health professionals, nerve conduction testing, palliative care, and respiratory physicians. The clinic sees people with MND who are eligible for the NDIS funding and aged care. I'm the OT on that clinic. It is generally accepted that carefully selected assistive technology can positively impact quality of life for people living with MND. The range of assistive technology people need throughout the course of the disease is varied and extensive. For example, mobility supports will range from simple walking sticks and frames to folding scooters and power chairs through to complex powered wheelchairs with specialty control systems. Some people may use all of these over the course of their disease. Similarly, with the range of bathroom aids and appliances, from the simple over toilet aid to the commonly prescribed bidet, from major and minor modifications to the bathroom to commode chairs with pressure care, tilt or travel capabilities. For people losing hand function, mealtime assistive technology ranges from simple adaptive cutlery through to complex, expensive options like the OBI robotic feeder. Positioning and pressure care is varied and individualised and frequently requires the allied health professional to problem solve and think outside the box. Manual handling equipment changes are often required rapidly as people transition from being able to step or stand one day to needing full support the next. And then there is access to computer and communication aids. This is a significant issue for many people living with ALS who will not have speech at the end of their life for months or years. Many will not have hand function or other movement either. Research has shown that providing means for communication will positively impact the quality of life of both the person living with MND and the carers around them. So what we offer and when is critical. Research also suggests that eye gaze devices have less impact of fatigue when compared to other access methods like laser pointer and methods requiring movement. A proactive approach is indicated to assist people develop confidence and skills using technology like eye gaze. And some people will need more support than others. The personal context for people living with MND is also complex and varied. Since it is a life-limiting condition with gradual and progressive loss of function, including swallowing and speech, and as a result there can be grief and distress for both the person and the family. There is loss of income and financial stress and loss of valued life tasks and roles. People face challenging choices about medical interventions like NIV, PEG feeding, and how and when they are going to die, how and where. In New South Wales, since October 2023, there is also the option to consider voluntary assisted dying. So when a person is experiencing such trauma, it can be challenging to introduce scary assistive equipment like mobility aids, eye gaze, or even bidets. My personal approach is to remind them, I will not make you do anything you don't want to do. I ask people to let me show them the equipment and talk about the equipment. But if you've seen it and tried it, you can still say no. This takes the pressure off, and I find people are more likely to engage. So what do people living with MND need from allied health professionals regarding AT? I believe they need a skilled, multidisciplinary team who are familiar with MND and who are familiar with the phenotypes of MND and the impact on disease progression and prognosis. For example, ALS is typically more rapidly progressive than PLS, and there are other types including bulbar onset, frontal temporal dementia, and more. People need clinicians with confidence in assessing for assistive technology in the context of rapidly changing needs. Clinicians with a proactive approach to AT intervention. And those clinicians need access to a large range of assistive technology, to skilled suppliers and reliable servicing and tech support. And of course, clinicians need to be comfortable with supporting people in the context of grief, loss, and end of life. So what are the issues in regional areas? MND coordinators report difficulty accessing allied health professionals to support their clients with MND. There are long wait lists to access services, high turnover, and high rates of burnout. Allied health professionals in regional areas report limited access to people living with MND, so they're often unfamiliar. According to a recent MND New South Wales survey, 48% of rural healthcare professionals reported having little or no experience caring for people living with MND. Anecdotally, therapists report feeling unprepared or out of their depth. Regional and rural areas also present challenges accessing the diverse range of AT available and associated continuing professional development opportunities and AT support. So this means it can be really challenging to find experienced AT assessors. So when our local MND coordinator advised she was struggling to locate NDIS therapists in the New South Wales Central West for a participant with MND who was progressing rapidly and needed urgent supports, we hatched a plan to try supporting the local area health service with a combination of telehealth, occasional visits, and regular communication. We worked together to meet the client's needs. Noting that people on the NDIS normally would be discharged from health services and need to be supported by private practitioners, but in this case there were none available. We were not entirely sure how it would go, but the local OT at the Central West neurodegenerative team was open to working together with me to give it a go. The client was based in Bathurst and the local OT was based in Parkes and travelled throughout the Central West. So the urgent referral was for Jude, and permission has been received for her participation in this presentation. Jude was a 61-year-old lady with MND. She had just transitioned onto the NDIS. She lived at home with her husband who provided full care. She had speech difficulty, a peg already inserted, difficulty walking, difficulty with transfers, and she was using some equipment from the hospital loan pool. The request was for a FlexEquip referral for urgently needed equipment. FlexEquip is the MND New South Wales equipment loan pool. Equipment must be requested by an allied health professional and they are responsible for the setup and safe implementation of the equipment. I met with Jude and her husband on telehealth and talked through her equipment needs. I was also provided the details of her local OT and established a connection to talk through what we were each able to achieve. We agreed on the equipment I would request and he would visit the home to set up the equipment after delivery. He would also collect the hospital equipment on loan. So the local OT attended the home to set up all the equipment supplied by FlexEquip and I attended on telehealth. I followed up by liaising with suppliers for small equipment consumables that we had identified Jude needed, and I was doing the NDIS purchase requests. All email communication with suppliers or stakeholders CC'd the local OT, the NDIS coordinator and the participant. This ensured we all knew what was happening and who was doing what. After the first visit, we had an initial discussion regarding a folding powered wheelchair for mobility, and Jude advised she had a family member who worked for Sunrise, so that was really helpful. And we briefly discussed eye gaze communications. Jude advised at the time that she was not ready to consider eye gaze. There was a lot happening at once and it was a lot to process in the one visit. While it may have been a bit much for Jude, I believe it was important to mention the option of eye gaze and alternate access for communication and start her thinking about it, because I was aware she was rapidly losing her speech and her hand function. And she was still on the wait list for a speech pathologist. I ended up visiting Jude 3 times in total, alternately with the local OT, mainly to set up equipment and sometimes bring equipment which is easily accessed from the Central Coast. I bought things like a swivel table for the recliner chair, low-tech computer access options, and a small folding commode chair, the Shower Buddy Eco Traveller, since this was useful when they travelled to Sydney to see her daughters. I set up the folding power chair after it was trialled remotely at Sunrise Medical and I was videoed in. When I was there in person, I explained eye gaze to Jude. Just letting you know, it will look a bit like this, it has a little camera here, this is how it works, etc. It's my experience that talking about things like this can take the sting out of it. If an allied health professional is calm and confident, reminding the person they have control and can say no if they don't want it. Before long, Jen asked for a computer that she could use. There was still no NDIS speech pathologist available, even though she was on a wait list and was marked urgent. We were advised that the local area health speech pathologist had very limited time and therefore focused on dysphagia management. I proceeded with eye gaze technology by requesting a mid-cost hire through Assistive. Mid-cost was quick and easy to access, since the device can be hired for 12 weeks and this can be extended towards purchase if needed. In metropolitan areas, I've always had the luxury of a skilled speech pathologist to help set up eye gaze. However, I was aware that Assistive can provide clinical and technical support with the hire, so I knew I had the backup assistance as needed. The local team advised that they were not familiar with eye gaze and therefore they would not have initiated it. I attended in person to set up eye gaze with Jude, and I had remote technical support from Assistive. The social worker and OT from the Central West team attended the setup to observe and learn. The social worker attended in person and the local OT was in Parks, but on a telehealth screen so he could also observe the setup process. We set up a Surface Pro with Grid. I'd asked Assistive for a simple communication system, knowing this is a person who has literacy skills and just needed access. At this point, Jude was still waitlisted for a speech pathologist input after the July school holidays. When I was leaving the appointment, Jude said, "Thank you for helping me. I want to write my own eulogy." By the end of July, Jude had passed away, 4 months after she was referred, 8 months after diagnosis. People living with MND simply don't have time to waste, so timing is critical. B was a second client in the same region. She was a 64-year-old lady who was also qualified for the NDIS. She was moved into SIL accommodation after a period of hospitalisation from numerous falls. B required complex supports, including a tilt-in-space power chair set up through FlexEquip, eye gaze setup, manual handling transitions from Sarah Steady to Salsa stand aid to ceiling hoist slings. Transfers. My role included supporting a team of NDIS allied health professionals and her care supports. Belinda was accessing AT from both FlexEquip and private AT providers. So in this situation, B had an NDIS allied health team with Vivability who just needed support with the complexities associated with her rapidly changing condition. And despite their trepidation, I went ahead and organised eye gaze for her communication soon after receiving that referral. I'm pleased to advise that the speech pathologist involved embraced the opportunity for learning and went on to support B and her care team by setting up eye gaze access to email, text and communication, which she could use while in bed, at the table and in her wheelchair. I mentioned to B that I would be presenting today about assistive technology and in particular the impact of technology like eye gaze, which some people may not be familiar with. And she responded with this: "I would be in a very lonely place without it. Makes the difference between having a life or being completely isolated." It reminded me that we should not underestimate the impact of these technologies. My involvement is less now with Bea and her team, but we keep a weekly half-hour meeting in our calendar to check in on where things are at and help problem solve issues arising. So my reflections on this experience are as follows. It seems that allied health professionals in some regional areas have less exposure to complex assistive technology such as eye gaze or specialty wheelchair controls, and this can result in avoidance and feelings of incompetence. There's a risk that people living with MND will not have access to technology which can help them engage meaningfully in valued life tasks and roles. Allied health professionals in regional areas are likely to respond positively to opportunities for learning, mentoring, or direct support in specialty areas of practice, such as MND and AT. And equipment loan pools like FlexEquip can be effective in providing access to AT in regional areas, particularly when they're willing to partner with local providers. So in terms of a call to action, how can we develop communities of practice to support allied health professionals to increase confidence and skills in AT and supporting people living with MND? How do we measure the impact of attempts to support regional therapists in this space? Is there an opportunity to partner with regional areas or clinics? And lastly, if people with MND do not have access to assistive technology for communication and mobility, comfort and safety, then what is the impact on quality of life? I believe there is much to be gained by supporting clinicians who are willing to work in this space, because despite the challenges, it is an absolute privilege to be able to support people living with MND. Thank you for listening.